Hello. That sounds better. Yeah. Okay. How do we do questions?
It's up to you.
As and when they arise, or
It's up to you. I mean, we have to complete 2 hours, so I don't think it has 2 hours.
this is my first time to Memphis. Yeah. Been to Tennessee before, quite a few times. Not to this. So are students expected to ask questions? Very good. So then closed captioning enabled means when it's recorded, the captioning will come automatically, right? Yeah. Okay. I mean, the time might move as well, so I don't know what a better, maybe. Okay, yeah, probably better here. Yeah. Yeah, sure. Yeah, let people walk in and then, yeah. Are they already asking questions?
No.
Did you bring the six pack? Six pack may not even be enough, actually. So you need multiple of those. Close enough. These chairs are super fancy. Yeah. Also funky, I mean, the whole ergonomic. Yeah. Yeah. Okay.
Okay, yeah, so welcome everyone. This is we have a second speaker in the Technology Serve and Humanities speaker series. So I'm the director for this series for the second year. Today we are very happy to have Professor Abhay Mishra from Iowa State University. So I have known Abhay for more than 10 years right now, ever since I was a PhD student. And when he was on the faculty at Georgia State, they tried to hire me. It did not work out, so I came here. But that's a different story. But either way, what Abhay is going to talk about is how technology has been used in healthcare, where exactly it worked and where it did not work, and what the future holds like, based on a decade of research in this domain. So with that, Abhay, I will leave the floor to you.
Thank you. So thank you everyone for being in this talk. I'm delighted to be in Memphis for the first time in my life. Thank you to FedEx Institute for giving me the opportunity to come and present my work. Delighted to be a part of this Technology Serving Humanity talk series. It's prestigious. A lot of people have come and presented their research, and so delighted to be a part of this. I've been studying healthcare now for more than 15 years. And I've been fortunate enough to study healthcare from many different perspectives. So perspectives that physicians use, that hospitals use, that group practices use, that patients use, that policymakers use, and that managed care organization systems use. So there are a lot of moving parts in the healthcare industry. And fortunately, over the last 15 or so years, I have gotten an opportunity to study each of those parts. So in the talk today, I am going to summarize, give a synthesis of 3 studies that I have done. One that focuses on hospitals, one that focuses on physicians, and one that focuses on patients like us, just to give you a sense for how technology can be used and misused and abused in the healthcare sector. And then I will conclude my talk by providing us with some perspectives on what I think the future holds with the recent slew of technologies in AI. How is the nature of work going to change for physicians? And how the nature of relationship is going to evolve between physicians and patients like all of us. Please feel free to stop me at any time. Let's have a vibrant conversation. I don't need to finish, although I think I will be able to, considering the amount of time I have. But anytime any questions arise on anything, this is a rather condensed talk. I could pick each of these papers and present that one paper alone for 1.5 hours, which is the typical research length talk. So go ahead and ask questions of all sorts. And if I can't answer those, I will ask my much smarter co-authors who will be able to answer your question. So, let's just go ahead and, I think it's stuck now here, possibly, or there we go. Yeah. Okay, so this is my family. Let's move this away. Can you? Oh, this, right? Yeah. Can we move this somewhere? No, that's gonna stay there. This is my family. My family consists of Mango and 4 humans. Mango has 4 humans. Mango is a recent rescue, and she is a part German short-haired pointer, so typical of pointer dogs, hunting, very energetic, very loyal, full of energy, loves to give kisses, loves children, loves animals, wants everybody to play with her. She gets offended when people on walks don't play with her. She's like, hey, have you seen me? Come talk to me, come play with me. Total escape artist, Houdini, runs away. And a lot of fun. We have twin children who are very delighted to have this dog, and there's my wife. The dog has added quite a lot to our life in just the 2.5 weeks that we have had. But the children have been appealing for a dog now for 2 years, and we finally gave in and got them a dog that they wanted. So that's the most recent development in my professional career. Now, I don't know if it's working or I should check. It is switched on. Well, you know what? I'm going to just probably do this. This is a picture from 2009. My parents were visiting me and my then girlfriend, now wife. This is a picture from Atlanta airport, and we had just received my parents. Just a year before, in 2008, my mother had undergone a very serious surgery in a tertiary care facility in Calcutta. This hospital at that time was using a rudimentary information system, which was not connected to anything. Each physician was doing his or her own thing. They were writing medications without any decision support at the point of care and without any help in terms of which tests, procedures, medications to recommend. And so different physicians had no sense for what everybody else was doing beyond just the paper record that you had. And they did. My mother had multiple chronic conditions and an acute condition for which she was being seen. And the medications that were prescribed were actually going to interact with one another. And one doctor wrote a dosage that was 10 times what my mother required. And so you can already begin to see the context forming for what we're going to talk about. Luckily, one of those mistakes was rectified by the pharmacist, and the other was caught by a nurse. Okay. And at this time, the picture is from 2009. The context I explained to you was from 2008. I had been studying healthcare already for 2 years. But my study focus was largely the United States, and this concretized the ideas I had. And in my mind, there is no other industry that is more consequential as far as the use of technology serving humanity is concerned than healthcare. So what better use of technology than to actually save lives, give people a better quality of life, give people access to healthcare that they really need. And so since then, I have been trying in my own way to study healthcare and in many different sectors. And so over the last 15 years, I have been fortunate to collaborate with a number of different entities. I have worked with large hospital systems like University of California, Davis Medical Center. I have collaborated with national and international bodies like American College of Physicians and American Medical Informatics Association. I have worked with governmental agencies like Georgia Department of Community Health and Georgia Southeast Health District, private corporations like Pruitt Health and Pfizer, not-for-profit organizations like American Red Cross, and pretty close to us. Actually, my journey in healthcare started when I visited the Coastal Family Health Center in Mississippi. This was right after Hurricane Katrina, and this particular organization had centers in Bay St. Louis, Gulfport, and Biloxi. And I was able to see firsthand what paper records could do and what the potential of technology was. So this is one sector where IT use and the use of data analytics can have a consequential effect. And I'm going to quote Peter Sundergaard, the senior VP of Gartner, and he said, information is the oil of the 21st century and analytics is the combustion engine. So don't have to explain to this crowd what that means. The goal then is how can we take the enormous amount of data that the healthcare industry generates in many different forms, at many different levels, data generated by physicians, by nurses, by pharmacists, by R&D organizations, by patients, by health systems, by social media in many different forms, in textual, image, audio, video, and many different types of forms. So we have a lot of data in the industry. In fact, healthcare industry is one of the largest generators of data in the whole world. But when it comes to actual use, actual deployment, actual exploitation of data, we have been saying this now for 15, 20 years. Even now, in this day and age, healthcare industry is far behind others. So what can we do here? Before we get to answer that question, I'm going to paint a picture of the US health system. And let me provide the caveat. The talk today is based not on Indian health system. It's based on the US health system. The idea being that the structure of different health systems in different countries is very different, very, very different. The regulatory structure is different. The incentives are different. The way hospitals, insurance, other entities are organized is very different. So this is focused on the US. So I'm going to paint a picture in front of you before we take a deep dive into the use of technology and its impact. So healthcare industry in 2021, it was $4.3 trillion, about 18.3% of our GDP. That's expected to rise to 6.8 trillion by 2030, which is 21.2, which at that time is going to be approximately 21.2% of the GDP. So again, no news to the audience in this crowd. Healthcare industry has been, and the costs have been appreciating at higher than the rates of inflation. Healthcare industry has been growing at a much faster rate than the average economy, and it's taking a larger portion of an expanded pie. So our economy grows every year, and healthcare ends up taking a larger chunk every single year from that pie. So we are spending a lot of money, almost $13,000 on every person in the United States in 2021. If you didn't seek healthcare in 2021, for those of us who were at lunch and we were talking about how some segment of the population does not seek care, that money was spent somewhere, right? And so we have the highest per capita and total expenditure in the whole world. But let's talk about what we get out of this. The quality is not very good. We have been slammed by all kinds of organizations. So the Commonwealth Fund, among similarly developed countries, we are the last in terms of quality of care, with 37th in overall performance, 72nd in the overall level of health, 50th in life expectancy, 48th in infant mortality. And if our system were as good as the one in France or Japan, we would have close to 100,000 fewer deaths in the country. That's on the one side. Also, particularly important for the talk today, for what I'm going to say, is there is a huge amount of variation in the outcome and the quantity and quality of care received by different demographic groups in this country. So this is not me saying, this is decades of research establishing that the quality and quantity of treatment received by different demographic groups for the same conditions is very different. So imagine a situation, two people have similar symptoms, similar disease conditions. Both of them present themselves to hospitals. One of them receives a better quality of care in comparison to others. And this happens systematically, and this has been happening for decades now. And there are effects that you see across in different demographic groups. So how do we address this? What is the root cause of this? How do we address this? The next item I'm going to talk about is productivity, understood in economic terms. So McKinsey in a 2019 study said that improvements in the industry can save between 1.2 to 2 to 3, $2.3 trillion in 10 years. So that's 10 years. If you cut that down, if you divide that by 10, you're looking at between 3 and 5% net savings of the 3.4 or $4 trillion that we're talking about. That's money that could be used for a number of things. That's money that we don't have because the system is not very efficient. If you look at the entire economy as a whole, the healthcare industry's productivity is far behind the overall economy. So when you take a look at multi-factor productivity growth, which essentially means taking labor and capital both into consideration, two factors of production usually, right? If you take a look at that, in the healthcare, in the hospitals, it is 0.1 to 0.6% based on who's reporting and who's doing the study. Of physicians, it's 1% increase. But for the entire economy, it's 2.25%. So that, that we're like 1%, 2%, big deal. It turns out that 1% change every year accumulated over 50 years ends up becoming a few $1 trillion, right? So that's a lot of money we are talking about here. So what can we do to address some of this productivity aspect? The access part. The access, again, I'm not breaking new grounds here. This is all well established, but we have also found this in our research. There is huge disparity in who gets access to healthcare. So there are these barriers come based on income, based on location in terms of rural, suburban, and urban, based on race and ethnicity, well established that minorities have far fewer and worse access to care than majority groups. Gender, women have had trouble accessing care and convincing healthcare providers. They're again well established that when women complain of pain, that physicians a lot of times just ignore those and not give the corresponding treatment necessary. Older people have trouble accessing care. People with different sexual orientation have trouble obtaining care, and disabled people are not able to access the same kind of care that they want or need, particularly when it comes to access to specialists or for mental health. Again, at lunch today, we talked about mental health. Mental health is a big unexplored 800-pound gorilla here that sometime is going to explode in the world. In terms of what has happened since Affordable Care Act, before ACA, we had 45 million uninsured people. Even now, 2021 data, we have 27.6 million people who are uninsured. And the reason for this is the cost of insurance is very, very high. If anybody tried to buy insurance on the state's healthcare exchange, they're a high deductible, not worth much, and cost a lot of money. Yeah. Yeah. Yeah, so this is cost of insurance for employees and also for employers is increasing 8 to 10% every year. We have the same deal at Iowa State where the monthly deductible is going up. And a lot of people don't know. A lot of people don't know how to work the insurance exchange. A lot of people don't know how to get it. A lot of people don't know that they're eligible for a number of governmental public assistance programs. In terms of financing, not much that I want to talk about here, but we have a system where the healthcare expenses are financed through both public and private sources. Public sources account for 49%. And so we have one Medicare program. This is run by the federal government. We have 50 Medicaid programs run individually by each state. We have Veterans Administration, Children's Health Insurance Program, and Indian Health Services, which is again run for the Native American population, funded exclusively through federal government. These are financed through payroll taxes, premiums that we provide, federal government revenues, and state taxes. Private insurance companies, all of the ones that most of us get through our employers, they together account for 39%, and out-of-pocket and private payments still account for 12% of the healthcare expenses. So largely painting a picture of how the structure of the US healthcare system is. Medicare, 50 Medicaid programs, 900 insurance companies across 50 states and Washington, D.C. and other places, hundreds of thousands of private employer-sponsored programs. As many employers as there are that are offering health insurance to their employees, at those many private insurance plans, because every plan is different. Every plan is structured different, administered differently. We have different rules. 6,000 hospitals, 9,500 urgent care centers, 65,000 long-term care facilities, about 230,000 physician offices. So why is this important? This is important because the US healthcare system is a big behemoth. It's a large ship which cannot do course correction quickly. The pace of change in healthcare is slow. It is deliberately slow. It does not change very quickly. I am not too optimistic of a structural change here. So we are not going to suddenly become a completely market-driven healthcare. We are not going to become a completely public sector-driven healthcare. The structure we have is the structure that we have to work with. Medicare for all is not going to happen. Neither are all of the government programs going to go away. The problem in healthcare is a lot of it is policy and politics driven, and we are a side effect of that. So a lot of times discussions go haywire. On the technology side, we are still struggling with information sharing and care coordination. So things are far better in the last 10 years. So after the HITECH Act was passed, about $35 billion was spent on tooling up hospitals and physician practices. So now you see most places you go to, I go to, doctors have EMR. So our information is stored in the electronic medical record. Where the problem arises is when that information has to go from one organization to the other. So despite the availability of health insurance exchanges and HL7, which is a standard used, there's not much interoperability even now. The record created at one place cannot seamlessly be used at another place, and that's a problem, which means you cannot use prior records for decision-making, for better diagnosis, and so on. And so if we were to use technology and analytics in a reasonable manner, in a productive way, we can have many, many good impacts. So devices, wearables, and all the health apps that we see on different platforms, they can help us manage our own health in a better manner. We can have healthy lifestyles. If we use clinical systems in a reasonable fashion, those could technically, ideally impact mortality. They could lower mortality, lower morbidity, lower rates of infection, and increase the quality of life. Those same medical systems could reduce healthcare costs by reducing waste in the system. They could provide more information to all of us, patients like us and others at the point of care. These are your various choices. With patients like you, this particular treatment has worked better. What do you think? So you're making joint decisions with the physicians, not just taking decisions that the physician has provided. Enhanced efficiency, share that information with public health. So if there is a sudden spread of epidemic in a geographical neighborhood, say part of Memphis is seeing very high rates of diarrhea. Sorry for painting that picture. And so you're saying, well, why is this? Is it because people ate, this is a group of people who are related to one another and they ate some food, or is this something more general going on? And you and I may not know this, but once that information is shared with public health officials, they can get the signal and they can take actions very quickly. And also, there are technological solutions, analytical solutions, one of that I'm going to present, where health disparities can be reduced. And before we get to the studies, one final slide on what data we are talking about and how much data there is. So healthcare in 2020 generated 2,314 exabytes of information, which is 1,000 terabytes, 1 million gigabytes. If I were to give you a picture, if you think your laptop has 1 terabyte of storage, the amount of information generated by healthcare industry in 2020 would take 2.34 million laptops to store. That's a lot of information, right? This is coming in all of these different forms. The amount of information generated is increasing 25% year on year. And you have all kinds of data from insurance companies to doctors to patients to the information that's shared between hospitals and their supply chain providers and other partners, and an enormous amount of information right here, pharma R&D. So the goal is, how are we going to use this to impact humanity? So the first study that I'm going to talk about takes a look at how technology can be applied by hospitals in an inpatient setting. So patients have a condition. It could be either a chronic condition or an acute condition. Acute conditions are those, getting injured in an accident, getting injured in fire, falling down, gunshot wound, accidental ingestion of poison, stuff like that, where there is not an underlying pattern. You've not been dealing with it for a long period of time. So what we did is we said, okay, can technology make an impact on the quality of care patients receive in hospitals and the cost of care? And it turns out that it's not an easy question to answer. Why? Because different hospitals apply different combinations of technology at different points in time. Some will apply a decision support system today and provider order entry system and electronic documentation next year. Others will apply archival system, picture archiving system today, and an electronic medical record next year. Some will apply them at the same time. Some have patients that are largely chronic condition based, and some have patients that are largely acute condition based. So it's very difficult to tease out how technology is going to impact healthcare and humanity. And so what we did is we took a look at how HIT, or health information technology, is used in clinical functions. If you look at hospitals, they have clinical functions. These are directly related to providing care to patients, but they also have business functions, supply chain operations, administrative functions, where they're taking our information and billing us. And we figured that the highest impact that technology can make is on the clinical side. That's where most of the costs are derived, and that's where most of the quality could be impacted. So we took a look at primary and support clinical functions. Now, if you think about when you go to the doctor in a hospital, what is it that the doctors are doing? Why do we get admitted in a hospital? Say again? That's the end result. From our side, if we are not feeling well, why do we go to see doctors? Why do we get admitted in hospital? To feel better, to have the doctor diagnose our condition and to prescribe treatment procedures, right? So those are our clinical functions, and those we call primary clinical functions. So diagnosis, decision-making, and prescription of medications, treatments, and procedures. What are support? How do doctors actually figure out what may be wrong with us and what treatments to provide? They figure that out by trying to extract information from us or if there is prior record about us, then by looking. So we say there are support clinical functions like documenting our conditions and looking at prior results. If I have been a patient at a hospital, or if I happen to belong to a hospital that can share information with another hospital, when I'm admitted to a hospital, the doctors can view results and see, well, Mishra did not respond well to this treatment, this is what happened when blah, blah, blah medication was given, the heart rate and stuff. I'm not a qualified doctor, so I can't speak much to that. So that we think is support. That's not why you don't go to the doctor to show your record. You go to the doctor to get treated, to find out what is wrong and get treated. So we have the support primary kind of clinical function. So it's thinkable, it's possible that the use of technology in primary and support functions will have different bottom line implications. Then, if two technologies or multiple technologies are being applied at the same point in time versus at different points in time, they could have different implications. For example, imagine I am a doctor and a patient comes to me and I'm documenting their conditions. At that time, I have no decision support available. So I'm just writing what I want the system, the condition is, and I'm writing the dosages of different medications. That's one use. But at that point in time, if I also had a decision support that said, no, that's too much dosage, or the medication that you are prescribing is going to interact with certain else, or this patient cannot take this treatment because of these reasons, that's a different kind of impact. So what we are saying is, if technologies are being applied in different periods versus if technologies are being applied in the same time period, the impacts could differ on people, on the quality of care and cost. And then patients who have chronic conditions may have more information. Patients who have acute conditions may not have that much information. The way doctors treat those conditions are very different. And so the IT could also make different impacts on care. So we take these different contingencies into consideration in our study, and we'll take a look at two indicators of quality and one indicator of cost. So clinical quality, there are multiple ways to measure this. And we take a look at mortality. Somebody has died, bad quality. Somebody survives that hospitalization, not bad. Then you have experiential quality. This is, how was your experience? How did the nurses communicate? How did the doctors communicate? How was the overall experience that patients have in a hospital? And then the cost, which is based on charges. So this is the data that we collected. We analyzed 715 hospitals. We wanted to be geographically diverse. So our hospitals are in Northeast, West, South, and we also had data from Michigan, which was bad data, so we had to sort of throw that away. But the number of states that we have is a good representation. This actually handles about 33% of US population. So we had enough observations to sort of get a grasp for what was happening in the whole country. We had 5 years of data. The data comes from what is called Healthcare Cost and Utilization Project, American Hospital Association, which does an annual survey of all hospitals. And this is a survey. So I don't know if you have received, if anybody has been admitted in hospitals here, but what happens is after you are discharged from the hospital, a random sample of patients discharged are sent this survey. Used to be the case that this survey didn't mean much, but what the government has done now is, if the discharged patients are constantly digging the hospital, then their reimbursement rates are reduced by 1%, sometimes even more. So this has real teeth now. And so what we find is there is, yeah, question. That's a great question. The raw data, raw hospitalization data was multiple million hospitalization. These are aggregated at the hospital level because we are interested in studying the impact of technology on hospital level outputs. Correct. The data set, no, so we had to assemble that data. So what you have, the H cup data here gives you information about mortality and cost. Yeah. Again, so what happens is each state reports its data to AHRQ, which so it's still problematic, but what happens is the AHA, so this is for all of the people who are interested on the data side and data science side, AHA has given each hospital an identifier. That identifier is used in many different data sets. So AHA also has details for each hospital's different locations, how many doctors are there, how many nurses, what kinds of treatments do they provide. This identifier is also found in here. So you can then link. In the admissions data, you can tell if a patient was admitted for a chronic condition or an acute condition. There is a chronic condition indicator, so you can sort that out. The AHA IT supplement tells us what kinds of technologies were implemented in that hospital, whether the whole hospital had it or part of the hospital had it, and in which particular year, what component was implemented. So there's a whole amount of data. The consolidation takes time. For anybody who's interested in analyzing data on the healthcare side, it requires about 6 months of learning, just looking at the data, trying to combine. Yeah.
It's a very interesting study. My question comes from this whole increasing pattern of cannibalization of smaller hospitals or ambulatory care centers by larger hospitals.
Yeah.
And usually the ambulatory care centers are much more affordable and the rates are also much lower.
Yeah.
So actually the Center of Medicare and Medicaid Services, they like such cases, but they're all increasingly cannibalized to larger hospitals. Now, because you're collecting hospital data, did you also have the classification of what type of hospital it is?
Yeah. So we had teaching versus non-teaching hospital. That's the classification that you typically use. And the idea is teaching hospitals typically see more serious patients. So this is any analysis that you do here is very hard because people would immediately say, blah, blah, blah. The quality that you're finding, the mortality you're finding is worse in this hospital is because they're seeing more serious patients. Or this hospital is in a poor part of the town, so they're not seeing. So what happens is what HCUP has done is when they report mortality, there is a lot of data science going on there. That mortality is adjusted for risk. So if a hospital is seeing a patient population that is more serious than the average patient population, then it's already accounted for in that data. Risk adjustment is already taken into consideration there. And so what we find is it is really important to see the impact of technology in a joint way. If you do not consider the joint effects of technology, you're going to end up making wrong conclusions. So direct effects, if you just look at how did one technology impact quality of care and cost, you see positive results, negative results, insignificant results, all kinds of stuff. But when you start to combine, when you start to take into consideration joint effects of technology, you start to see some consistencies in the result pattern. But even that is, I wish I could say to policymakers and to hospital managers, do this, and this, and your cost of healthcare and the quality of care that you provide for all different types of patients will be better. And unfortunately, I have not seen a researcher who can make that claim yet, because different combinations of technologies have very different bottom line impacts. So the kinds and combinations of things that impact the quality and cost in a favorable direction. I don't want to say positively, because cost going high is not a good idea, but in a favorable direction for chronic conditions is different from acute conditions. For technologies, the way they are implemented at one time period versus across time period, some of those are good at some time and not the other. And so the message to the policymakers and managers is, and I listed this in my abstract as well, is IT is not a panacea. It is not going to be able to solve all problems for all hospitals, all provider populations, and all patient populations. We have to customize. And could be, if the idea is, no, we are going to take care of clinical quality first. First, we have to make sure that when patients come to our hospitals, we don't kill them. If that's the dominant aspect we want to impact, then we should try to influence the levers that directly impact the quality of care in the hospital. There's much more to, yeah.
I think it's actually more of a cost than solution cost.
That's a good question. So you do see impacts of IT on reduction of costs, but IT also adds cost to the hospital's operation. So there's also a perverse incentive structure here. So if the hospital the costs are reduced significantly, then that could have bottom line revenue implications for hospitals. So I have said this multiple times, I'll say it again, is in my opinion, we are going to see larger impacts of technology on quality than on cost reduction. Because as rational players, hospitals and doctors will find ways to inflate revenue somehow. But on the margin, we do see some impact on cost, and we wanted to. The second study focuses on productivity side. And we figured, well, this is the story on hospitals. And if you talk to 10 people, 10 policymakers and researchers, and say, who is the most important stakeholder in the healthcare industry? You're beginning to see some people mention patients now, but it's largely driven by the physicians, the doctors. They call the shots. Like in Google, engineers call the shots, not managers, right? In hospitals, in the healthcare sector, the doctors call the shots, not the managers again. And some of this is reflected very clearly in numbers. So 21% of healthcare costs in the country are directly related to services we receive from physicians. All of the services that they provide to us, diagnostic and otherwise, 21%. But forget about that 21%. Most of the treatment decisions are guided by physicians, right? So of the 79% that we cannot attribute directly to physicians, most of those decisions are, again, largely made by physicians. What treatment procedures are going to happen? How is the patient going to be shuttled between one care organization to the other? And so anything we can do to influence the work of physician and to make them even tiny bit more productive is going to have a lot of hopefully good implications on the entire health sector. And so just some more data, number of visits to physicians. So in a year, we are making almost 1 billion visits to physicians, which is about 3 visits per person in the United States. And about 61% of these visits are to primary care physicians. Primary conditions, visits to specialists are the other part. And so what I tried to study in this particular endeavor is, how does technology impact the productivity of primary care physicians? And in particular, try to take a look at electronic medical records. Anybody has family member, friend who's a doctor? Anybody know any doctor who likes to do a lot of documentation? Yeah. So the idea here is EMRs reduce physician productivity because they force providers to use drop-down menus or free text typing, both of which are slower than dictating. This is, we were trying to work with some physicians in Nashville. Nashville, as all of you know, has a number of health systems headquartered. It's a big healthcare center. And so the idea is, how will EMR impact the productivity of physicians over a period of time? So how do you measure? The very first question we had to struggle with is, how do you measure the productivity of a physician? Number of patients seen, right? Could be. How about revenue generated? How about how much time it takes to see each patient? Right? How about all of these are wrong? What is number of patients seen dependent on? If I'm seeing a very serious patient with multiple conditions, how many patients am I going to see? 1 or 2. And if somebody is a dermatologist and people are coming to them with some skin condition, they can easily see 35, 40 patients. The number of patients seen is not a good indicator of productivity. Right? How about revenue generated? Bingo. Revenue generated is a direct correlation with the insurance status of the patient. Private insurance versus public insurance versus no insurance. That's not a good indicator. And just for the same reason, number of patients seen is not a good indicator. How many patients you see per hour is not a good indicator. So this is a problem that not only us, it's been around, how do you assess the productivity of a knowledge worker is a big problem. And so what we have done in healthcare now, a lot of econometricians and measurement experts over a period of a decade focused on finding one metric called work relative value unit. So what this does is it takes into consideration how much skill is required to see patients, what is the level of mental stress that the doctor goes through, where is the doctor's office located, what overhead costs does the doctor feel in seeing patients. And when converted into WRVU, then the production becomes comparable. So if a neurologist, neurosurgeon has generated 30 WRVU, and a hematologist has generated 30 RVU, they're exactly the same. They may not get paid the same, but their production is the same. Now, a neurologist, a neurosurgeon may have seen just 1 or 2 patients for generating that RVU, whereas somebody else might have seen 25. It does not matter. So what we did is we standardized on WRVU. And the other point that is very important is, just like all of us talked, nobody wants to enter the information. Nobody wants to document. But once the information is documented by another doctor, bingo, it becomes very helpful to us. Now we can make decisions. Now we can diagnose easily. Now we can see what the patient's results were in the past. And so if you think about this, the productivity of physician after a technology is implemented is a function of how much do they need to do this versus decision-making and review. So the use and impact, what I will try to drive in all of the studies is they're very contextual. There's not a straight shot answer to questions on, well, what does technology do? Because it's very contextual and we have to be cognizant of that. So decades of research has shown that when a new technology is introduced that is very important for a professional's work, there is immediate drop in productivity. And then because you're learning, how do I do this? How does this work? What screen? Where do I go? Then there is a period of, and this is called adjustment cost in straight economics terms. Then there is a period in which you begin to learn, you begin to have some sense for how to use the technology, but you're not quite conversant with it. You don't know everything about it. So your productivity initially goes down and down and down and down and down. Then you try to recover a little bit, and then you reach a steady state where you know how to work the whole thing. At the steady state, maybe your productivity is higher, or maybe it is lower, or maybe it's the same. And we see that in healthcare. Yeah. Little bit different, but yeah, I mean, I have studied Brunson work in a lot of detail, but yeah, so you spend a lot of money on computers, but you don't see the impact on productivity because of many different reasons. Yeah. This is a direct picture of the tech that we was part of the team at University of California, Davis Medical Center. This is what we were dealing with before the computerization. And you can see taller than her, right? This is a $200 million Epic EMR. I'm pretty sure all of you know what Epic is. We studied 12 outpatient primary care clinics, 87 physicians in 3 specialties: family practitioners, family practice, internal medicine, and pediatrics. These are primary care providers. Now, a lot of people think I am internal medicine specialist and family practitioners are the same, right? Raise your hand if you think they're the same. That's great. I have a very well-informed audience here. Most people say, oh, they're the same. What are you talking about? They're not the same. These are people who largely see adult population, and they are experts on some chronic conditions, but they happen to also be primary care providers. These will see everybody: adults, children, very sick, not very sick, and they do not tend to focus on certain types of diseases. You can generally go to them for everything. And of course, they focus only on children, 18 years and younger, right? This becomes important. So we had a lot of data that we collected, and we were very careful because the entire story is around productivity. So you have to have very detailed, meticulous record of how doctors performed. So we got that information from the hospital's own. Why is this accurate? Because doctors get paid based on this. So doctors would not stand for wrong information there, right? And then Health Grades is a website. We got some information about when the doctors graduated, gender, stuff like that. Look at the information pattern on how productivity changed. And so this is months before and after the technology was implemented. You had average productivity around there. And the month as the technology is implemented, you have a sudden drop. And the drop keeps on going for a couple of months. Then you see some recovery going. And then about 5 or 6 months down the line, it starts to stabilize. So this is the picture for all the different specialties. See how this breaks out once we divide into different specialties. You're starting to see the blue is internal medicine specialists. They have fallen farther than anybody. On the flip side, they have risen higher than anybody. They are also the ones whose productivity has increased from before, whereas these two are statistically insignificant from each other, and they are marginally below the productivity level that they had before the technology was implemented, right? 6 months after. And so, well, what's going on? It turns out that internal medicine people, because they see complex patients many times, even in primary care setting, that in order to make decision and give them treatments, it takes them much synthesis, much analysis, much decision making. And when you implement a new system, they find it really hard to use that. But they don't do a lot of information entry, because information for them is entered largely by other family practitioners and others who the patient may have already seen before. And so they fall farther because they're taking a long time to learn how to use it for decision making. But once they do, because they don't have to enter information again and again, they can rise much farther. But family practitioners, you go them for cold, cough, stomach issues, fever, everything. Every single time you go, type. Pediatricians, the same thing. Kids need to go see doctors very frequently. Kids also need to go see doctors for well visit. No matter what the situation, the doctor has to type quite a bit. So information review to information analysis does not work very well for family practitioners and pediatricians. So that's what this entire slide is about. They suffer in the initial part during learning phase, but they recover quite handsomely, quite considerably. And it depends on the ratio of the amount of time spent on retrieval to information entry. Retrieval is decision making, analysis, synthesis. I am spend more time on information retrieval than on information entry. So from the second study, I want to reiterate the same thing we found in the first study, which is the impact of technology on hospitals, on physicians, is dependent on how the technology is used and who is using it and what the workflow is. So it's very difficult to make a blanket claim that technology is going to have good impacts on everybody. The third study is about inequity that we see in the US health system. So there are significant disparities. I don't have to convince you. Most of us have read about it, experienced it, seen it. Different demographic and socioeconomic people have different quality and quantity of care. You could get discharged earlier, later, depending on where you belong. And one of the reasons this happens is at the point of care, if when technology is used to discharge people, that this has been using biased data and using decision models that no longer are true. So this is a direct case of technology not serving humanity. When we are using decision models that don't serve people equally, we're not looking at equal outcomes here. Outcomes we don't even know, but equal effort in terms of people having equal access to healthcare, that is something that we are not seeing. So if Shrikar and I get admitted to the same hospital, but I am discharged after 2 days for the same conditions, whereas Shrikar gets to stay for 4 days, guess what's going to happen? Right? And so it shows up as what we try to take a look at is length of stay when a patient is admitted, how long do they get to stay? And if they are discharged prematurely, if they have not gotten all of the treatment, do they then come back as a readmission case? And how does that separate out for different demographic groups? So unfair decision models, biased data is what we are going to try to take a look at. And so this is coming from a goal that the WHO has created for itself. Health services must be timely, equitable, integrated, and efficient to improve the quality of healthcare. And equitable care is defined as providing care that does not vary in quality or quantity on account of gender, ethnicity, geographic location, and socioeconomic status. This is a big goal. I don't know how much time it's going to be before we can guarantee it or make progress towards it. But this definitely is not the situation now. So how can we make fairer models? How can we make models that take that inequity into consideration? So like I mentioned, length of stay and then patient readmission. Both of those data, if you take a look at length of stay and patient readmission, you will get very quickly that the data is non-normal. And the way in which these kinds of models are analyzed is by using quantile regression, which tries to fit a line through different quantiles in the data. And we found very quickly, very early, that what we were looking for was so not equitable, not fair at all. Yeah.
So, talking about the larger impact of human factor or just the data models of the algorithms.
So both of those things. So the algorithmic models are taking their cues from the data that we feed them. And so one of the researchers, what they did is they said, the way hospitals are figuring this out, when do hospitals keep you longer? They keep you longer when they think you are more serious, that you need more care. A lot of hospitals were making this decision based on the cost of treatment that a patient had already received. And the idea was, if a patient has already cost a lot, it means they're more serious, so we should keep them longer. The data was severely biased because there were systematic differences in the doctor's recommendations for which patient was sent for which treatment before the decision was made. And so if you take a look at two patients, X and Y, both same condition, but the doctors have already treated X much more quantitatively, more treatment than Y, it would turn out that X is more serious. And so X would then get to stay an additional 2 days, whereas Y would be discharged.
I didn't see this in this perspective.
Yeah. So that was just one. Obermeyer is the pay, the Obermeyer. This is a well-published, well-cited research that you guys can read. And there's plenty more. There's a lot of stuff here that is, yeah.
So what about, or how did you control for factors? For example, the hospital might be treating both the patients for the same amount of time at the same treatment, but probably one of them lives in a slightly more hygienic environment than the other for the readmission thereafter.
Excellent question. I'm going to show you. We have social determinants of health. So if you look at where do I say where the data is from? Not yet. It's coming. Okay. So you can get what is called SDOH, social determinants of health, where people live, what the pollution level is, what the crime level is, what the education level is, what the average income is. All of that is controlled in this. Yeah. And so when you do quantile regression, the residual that you obtain is an indicator for whether you're overestimating or underestimating. And we saw strong signs of overestimation and underestimation for different demographic groups, which was a clear signal that it was inequitable and we needed to do some stuff. So that's the data, about 496,000 patients from Florida and New York, more than 1 million admissions. And the US Census Bureau to take a look at what was happening, what the demographics were, and county health rankings is what looks at social determinants of health. Community level and health information technology variables, so we controlled as much as we could. We very quickly found gender, payer type, racial, ethnic, socioeconomic, and environmental disparities. Yeah. Sure. Question? Yeah. Yeah. And so the innovation in this particular study is we convert the quantile regression to a mixed linear integer programming model with constraints that are created in this research and algorithms to converge the solution quickly. So I am not smart enough to do this part. My co-author, his PhD is in industrial engineering, and he is much more algorithmic in nature than me. So he did most of the optimization part for this. And what we do is once the fairness constraints are integrated into the LP, we start to see some changes there. And it effectively reduces the residual gaps between, so remember residuals are a strong indicator for whether something is biased or not. It reduces the residual gaps without changing regression coefficients. So if you make the model fairer by making things worse for others, that's not the outcome anybody's looking for, right? I'm making this fairer, but you are screwed. That's not the idea here. How do you make the model better without making things worse for others? And we have done, quite a large number of simulations. We're fairly happy with what we have gotten. Much more could be done. Yeah. The LP model. How do we figure this out? And so, again, there are no clean solutions here, but hospital administrators, policymakers, and doctors need to see if certain demographics are being discharged and being readmitted far more frequently than others. And if they are, then they should question those decision models. So when new algorithms are being designed, we are largely people in the data science community. We are largely responsible for where the industries are headed. If we want better outcomes here, then we have to make sure that decision models that we propose do not optimize for the entire population always. That differences within groups are considered and given due importance. And so model validation should not only consider accuracy and performance, but also fairness for different groups. Because if you think about it, if you're optimizing for the entire model, it could be at the expense of certain demographic groups. And that is what is happening now. So you will see this being proposed by a number of leading researchers now that we have got to change this. And I think particularly in healthcare, but also in education, in criminal justice.
How do you define the fairness to have such groups of population in certain areas? I mean, it's not all going to be the same across.
It is not, which is why you do it quantitatively. If I am accounting for those differences in my model, then as much as you can statistically, you're comparing apples to apples. It's never perfect, right? If you can never take all of the heterogeneities away. But as much as possible through quantitative data, you're trying to see. And if you see stuff like this, I mean, this is, you pick up data from, I guarantee you, any state in the country. Any state in the country, and you start to analyze along the lines I have mentioned, you're going to see differences. This is not a question of anything else. It's a question of the way things have been done and the adverse consequences that some people have suffered. And I think it's time for a change. And so in summary, what I'm going to, from the 3 studies, that there are a lot of tricky issues here, conundrums galore. There's not one set of solutions that's going to take everything away, going to make everything all better. We have to contextualize. We have to be careful about, deliberate about the use of technology. And we have quite a large corpus of heterogeneous data, from hospitals to patients, to insurance companies, to pharma companies, text, video, all kinds. How do we use this properly? That's the challenge. And one of the challenges is, for all of us who do decision models, who do data science, one of the important points to consider is how things are similar to one another, right? It's not always very easy, as you can see here. Things are not always very similar. Things that are similar may not always be similar. And I know what some of you are thinking. You're thinking, well, men, women are not doing much better either. So it's not really easy to tell who's similar to whom. And this is, of course, in jest, but which patient population you're similar to is not always very easy to define. So we have to do that very carefully. Now it's time for me to pontificate a little bit, and where I see higher integration of all kinds of data. Some of this is already happening. So data brokers like LexisNexis, they are under no obligation to follow HIPAA, right? They're not direct provider, they're not covered entity. They collect enormous amounts of, I guarantee you, all of us have tens of pages of file with LexisNexis. And insurance companies are routinely accessing this data to price policies, right? That's going to happen. And in fact, now social media data is also going to be integrated. Now we have to figure out how this could be used properly. I see a lot of potential in text mining of clinical notes. Doctors and nurses are putting a lot of clinical notes out there. Much of that is not being utilized. So now there is some development on medical dictionary, using that dictionary to do a lot of text analysis of data. But if you look at research published over the last 10 years, this is sort of the Achilles heel. You don't see much of text data because number one, hospitals are not willing to share. Number two, when they do share, you don't know how to analyze that. Medical dictionaries have been lacking. We don't know what doctors mean when they're typing different, and nurses when they're typing this. I see a lot of use of deep learning for exactly the reason that we all know. Precision medicine, I see a lot of use of automation for diagnostics. Diagnostics are an easy case because diagnostics can take enormous amounts of data into consideration. We know the ground truth. You look at the picture, you know which one has cancer. So it's easy to train our models for diagnostics. It may not always be easy to train our models for decision making where human expertise is required. May not be possible or may not be as effective for different treatment procedures and medications that could be given. So I see some bifurcation of tasks here. I guarantee you in 5 to 10 years, a lot of the diagnostics will be offloaded to automation. And some of this is happening, much more of this is going to happen. And how we're going to do AI in healthcare is also very interesting. It has always been controversial. Raise your hand if you would like to see or be seen only by an AI agent.
I know what I'm going to do. Blood test, we do that.
There's no more surprise in my talk anymore. That's where I was going as well. But yes. Yeah. 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 And that's a great point too. I think some of that is happening and is going to happen more. So why this is important is I'm going to take you back 40 years because AI has been around for 40 years now. In the 1980s, when they started with expert systems, one of the first use cases that people discussed was, well, doctors are useless, let's replace them with expert systems. And that didn't happen, but it got all the doctors riled up. And replacing of physicians is never going to happen, I think, not anytime soon, right? And so Sean Jagatishwaran from J&J, pretty much saying similar things that we have talked about. The idea is there is a strong demand for automation. There's a lot of data available. Let's give the data to an agent that is analyzed. There was a question? Okay. So there is a lot of scope for the diagnosis side and analysis side. But on decision making and treatment planning, I think you're pretty much going to see physicians still taking the lead. Chatbots, has anybody used chatbot in an e-commerce setting? Customer inquiry, return policies. Everybody, right? So we are comfortable with this. And like most of us have discussed, AI chatbots might be good for non-critical conditions. Oh, stuff, I have cough, stuff. Is this viral? Is this bacterial? Who knows? Just don't take antibiotic for everything, blindly, stuff like that. So, but it can also be used for data gathering. So right now when the doctor's offices would say, enter your information so you don't have to wait for long, but there's not much data gathering from ours, not much diagnostic help, and this could be a great help, actually. AI agents can also be used for clinical. So imagine AI chatbots are talking, we are answering, rather than an actual nurse or a doctor typing that AI chatbot is integrated with our Epic system. And so that information gets integrated very quickly. Now, I will tell you that Epic systems and others make a distinction between information that we provide versus what the doctors and nurses actually type. So it could be the case that Epic might say, this was mentioned by the patient. This is not coming from the doctor. Even then, it's helpful. For clinical documentation, if we can help doctors with, a lot of hospitals hire scribes, so doctors don't have to document everything, but we can use AI agents for documentation. And like was mentioned, remote monitoring of patients using telehealth, using AI. So one of the best use cases is for patients who have had surgery or patients who are infirm, older. A very significant risk is of fall and breaking their hips or something, right? So, patients with Alzheimer's and others just walking away. And so you can use AI tools. Basically, you can feed enough data and train the models well enough that it can predict when patients might actually fall down, or at what point in time they might walk away from their home. And so one use case of this would be sending traveling nurses to take care of patients and making better use of those, rather than sending them to every patient just. And so in the short term, for more routine tasks, we see more AI-based support for more complex and complicated, involved decision-making tasks. More of the physician work. So the nature of work is going to change, evolve. In the long term, I wish I could tell you, I wish we could figure this out, how the nature of work would change. We would all be very, very rich. But one trend is very clear: more use of AI agents for diagnosis. This is going to happen. This I can tell you with a lot of confidence. In summary, I am optimistic. I'm also very excited for the role technology can play in serving humans better in the healthcare industry with some guardrails. The guardrails should be around the models that we use and the data that we feed into our system. Prior data is not always good, and prior data is not the way it should be. The model should be trained. So these days, there is a lot of effort going on in creation of synthetic data, and how synthetic data can de-bias some of the prior data that gets fed into the system. And you're seeing uses of this in many different social and healthcare conditions. And my last plug for fairness. Fairness is a worthwhile goal. Fairness is a goal that we have to aspire toward to make sure that something as important as healthcare is equally available to people. This is my most important slide. Thank you very much for having me over. Yeah.
So you talked about the technologies implemented and how is it impacting physician productivity, outcomes, so on and so forth. But I mean, with the generative AI stuff and everything that is coming into picture, In general, the tendency of human beings is it's human to err. I mean, if a physician commits an error or a worker commits an error, it's human to err. But if a machine commits the error, we'll have to treat the machine very harshly. We doubt the company who will happen. So my question is in the healthcare context, what impact do you see the technological errors would have on whether it's in terms of the outcomes or I mean how it is implemented because you can kill a patient, right? With the robot.
This is why the decision-making part should stay with the professional. That's a guardrail. You should not automatically, if the AI agent, if the AI has said, do this, we cannot blindly follow that. This is why the physician is not going away. That's the last line of control you have, is the physician. Because the technology is very good at analyzing data. There's no way there's hundreds of gigabytes of information analyzed so quickly, right? So the diagnosis part, there is no competing with technology. It's the analysis, it's the decision making, the actual formation of the treatment plan, the actual modification. That's where human judgment is required. So I don't foresee a situation very soon, I don't know what's going to happen beyond 10 years, that it's automated so much so that the data gets fed to the AI agent and the AI agent then starts to dictate what treatments to provide. That's not going to happen. Yeah.
What's your opinion? What do you think insurance companies feel about?
Insurance companies are all in on the use of AI because it might save them money, right? It reduces fraud. It could potentially reduce doctors' charges because they're going to spend lower amount of time. How doctors feel about this is one thing that we have to think about. I don't think doctors are comfortable with the technology much. Doctors don't like to lose power. I have yet to see a doctor who says, you know what, yeah, I don't care what my patients think. Even now, a doctor, if you go to see them in their office, more likely than not, they would not seek the help of a decision support system because they like to be seen as superior, like all-knowing. I know how to treat you. So it's a cultural change as well. Maybe, with the new generation of doctors and training, this could change, but we're not there yet.
Especially during COVID, we were encouraged to use telehealth.
Yeah.
I don't remember Cigna has one.
Yeah.
I had like a sinus infection. It's easily diagnosed through telehealth.
Yeah.
Within 5 minutes, prescriptions called in to my local Kroger. And I remember even thinking, man, like artificial intelligence is one day it's going to still be that. For
sure, I think we have to move in that direction because if on the one hand you see numbers that say we need 100,000 more nurses and 200,000 more physicians, and yet people are afraid to use technological tools for everything. So I would be very comfortable using telehealth for routine conditions.
I think what your slides, 60% is primary care.
Yeah, 60% visits.
Of those 60%, a large majority of them are cold sinus. I mean, your routine seasonal visits that you're in and out of doctor.
So I'll wear a wearable when I go to my doctor. Downloads all
It
the
does, yeah.
information.
Yeah.
Prints it out. She looks at it. She says, "Yep, it's good," or hey, we're going to go ahead and change some of your meds.
Yeah.
Based on everything. So it's really interesting, that she should be younger doctor.
Yeah.
And it makes a big difference.
Yeah.
She's dependent on me for my wearable to tell me what my blood sugar is, how well it's doing.
So that's the doctor-patient relationship that I'm talking about because this is going to evolve as well. Right now, doctors are telling us what to do. And the way this is going to evolve is it's going to be a joint decision-making. So what you do is going to influence what the doctor does. And rather than you or me telling the doctor what we did, we walked, it's going to come directly from a verified source.
But it gives a better idea.
Yeah.
Especially if I'm having a bad, and it's like, the sugar is 320. What have you been doing? It's like, well, how?
Yeah.
But
Candy corn. Yeah.
I said, yeah, it was fine, just lay off.
Yeah.
That kind of stuff, so we don't need to like to change or monitor and stuff. But I just think it's interesting that I think a lot of the wearables are gonna become an interesting part of like the doctor-patient relationship. I think of that cardiac commercial where you're checking
Yeah.
your heart,
Yeah.
and it's like, if you once a day, if you did that,
Yeah.
and you go to your cardiologist, it's like, well, let's just see what you've been doing.
Yeah.
You know,
Yeah. I mean, it's coming. It's already happening, and I think it's a matter of time before all of us are going to be in that loop. So,
I have more, let me clear it out.
yeah, absolutely. Yeah.
I mean, back in the days when mobiles first came into it,
Yeah.
a lot of us would remember phone numbers of lots.
Yeah.
If we take away the decision making from the doctor, don't you think it will influence the quality of doctors who study?
We are not taking the decision making away from the doctors. That's the one thing we are keeping. We are taking the diagnosis part. So a lot of the training that doctors receive is still on the diagnosis side, because all of the leading questions doctors are asking is, think about a big tree. They're eliminating as many branches as possible from that tree, right? So they're still trying to diagnose. The decision-making part, I mean, if you think about AI systems, expert systems, a lot of those are trying to help with decision-making. I think humans, especially in complex situations, uncertain conditions, new conditions for which data is not available, what are you going to do? I mean, with our expertise, sometimes, so for example, Turnitin, for example, may not catch something, but when we look at this, we look, this is just not well done. And, so I think human judgment is necessary. And we should not take the decision-making part away from that. The last point should be the human. Yeah. Yeah. Yeah.
So when you think about the patient models, data models, and AI corporate education in the future, after that point, in the long run, do you think this would affect, or this would sway natural decision making capacity?
Could be.
Back in the day, we didn't have those cameras. We used to see the mirrors and
Yeah.
used to talk.
Yeah.
But most of the people can't talk today without this camera.
Yeah. Most people had better memory of directions, which we are losing now. Most of us could do differentiation and integration on paper, which we probably can't do anymore. So I think this would take some toll. Some of the capabilities might be compromised. Yeah. Yeah.
I'll be curious what you would say to somebody like my father, who I just had this conversation from last week. He had atrial fibrillation.
Yeah.
So he has a pacemaker put in now.
Yeah.
And the doctor, they go in and replace the battery.
Yeah.
His big thing is the government's going to have access to my data. Because anytime he's wearing that, he's just funny. He's very religious, but the government has access to him. But what would you say to someone who says, this technology is great, but I want to be very careful with it, sure.
And so those guardrails are already there. The government does not have access to our data. It's the provider, right? And the provider, there is not a federal hospital, except for VA. VA system, of course, is the federal system. And yes, there are breaches all the time. Large-scale breaches sometimes by hackers, but it's not the government. Your data is compromised by somebody who's going to render the hospital's information system useless and ask them for $10 million before all of the stuff is unencrypted. The stuff that's being stolen and sold on the dark web is not the government. It's hackers. Sometimes these are state-based actors out of Russia, Iran, North Korea, other places. Sometimes these are just plain hackers from our own country. Sometimes so the government, all of the information that I reported to you about patients, So what happens is when you get admitted to a hospital that takes federal money, which is 99% of all hospitals in the country, you cannot survive without Medicare and Medicaid dollars coming in. Each admission is cleaned up and reported to the AHRQ, the federal body, right? But they do not know from the patient number that this is Mishra. Number one. Each one, if Mishra has gone to hospital X today and hospital Y tomorrow, it may be possible to track that across long periods of time, but the government cannot tell that this is Mishra, right? There are specific rules in place. So when I use HCUP data, there is a specific clause there. If I am analyzing a condition that has 11 or fewer people, I cannot report that result. Because when there are so few people in the whole country, it may be possible to identify them. And this is coming straight. So there was a governor of Massachusetts, this was about 10 or 15 years ago, based on their condition and what was reported publicly, they pointed the finger and said, that's the governor of Massachusetts.
A professor named I had one on my page.
Okay.
So she matched 3 public data sets, which are public data sets.
Yeah.
And she joined those tables and analyzed it. And she identified 87% of the total US population could be identified based on their date of birth, their zip code,
And name.
and their gender.
Yeah.
And she figured out the governor of Massachusetts data set.
So this event occurred more than 10 years ago, but yeah, with somebody's name, date of birth, and zip code, there is a 98% probability that you can tell who they are. So when hospitals report this data to AHRQ and the own state level regulatory bodies, the identification is taken away. So HIPAA has very strong rules for this now. If the data is de-identified, then there is no risk. And there are 18 different indicators that all need to be taken away. Phone numbers, license, name, date of birth, blah, 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 all kinds of stuff needs to be deleted before you can report the data. So the government is not after people's health data. The government is after data from a statistical perspective, but not, hey. The other thing is a lot of people are concerned about fraud in the system, and the healthcare system has fraud for sure. But you will hear this, that there's 10% fraud in every program. And so Florida, not too far from here, Florida is the center for Medicare fraud in the whole country. And you got big pill mills and doctors. There's our senator from Florida has also gotten, Rick Scott has gotten involved has pleaded guilty or company. So there's a lot of stuff there. There's fraud in Medicaid, there's fraud in SNAP and everything. But on the whole, I think I am optimistic. Technology is serving humanity with some guardrails is what I would say. Yeah. Yeah.
To get around it, a lot of that paper system.
They did.
To get around being locked out of the system so that they could continue to take care of patients. And we were kind of discussing how kind of going back to the old school way of doing things because it was more secure.
Yep.
Than the new way, which is like everybody can get to it. So it's like I can go to my health portal and I can see everything, and my other doctor here can go to the health portal and see what the other doctors have said. Before you just kind of they would send copies of
So one of the other things that's happening is people are losing the skills to work with paper-based systems now, as an impact of technology, like you mentioned. So that is happening. But yeah, when I was in Georgia, every healthcare system had been compromised, and they ended up paying $10 million. But when the hackers broke into City of Atlanta system, they refused to pay the ransomware. Sorry, the ransom, and said, we are going to go back. And so they were not able to bill the residents for, I think, a month or two, but they said, we are not paying ransom. It depends. I mean, even now, one of the other options that of course people have is remote storage of data and applications, right? So if you could have Epic system, or if, on the other hand, if you have cloud-based system, you could get the system back up and running very quickly.
So I looked into a little bit about blockchain.
Yeah.
With medical records and stuff.
Yeah.
The biggest thing, of course, is storage. It's just not enough storage.
Yeah.
For images and everything for everybody.
For everybody. Yeah.
And so I thought it was really interesting. It's like, well, yeah, blockchain is secure, as we know, but you build it correctly.
Yep.
But it's like just the cost benefit really. But yes, you got a secure system.
Yeah.
But it's going to cost you
A lot, much more. Yeah.
Yes, that brings us to the end. So please give a big round of applause for the.
Thank you so much.
Thank you, Joe.
Surprisingly, got no questions from the audience as well.
Okay, so.
Yeah, just delete the slides from there. And I will